Hello, this is Marshall Riddle from MCOL, welcoming Philip Ronning, Principal, Ronning Healthcare Solutions. Thank you for joining us, Philip.
You're welcome. Glad to be here. I'm talking today about the accountable care and formal organization, and the emphasis here is on the informal organization. Organizations today are largely formal organizations built out of the industrial society philosophy, and the challenges facing healthcare today require us to look beyond the formal organization to the informal organization. As the first slide indicates, bending the curve, which has become a mantra for accountable care and is the reason for accountable care. This large growth in the cost of medical care since 1980 has resulted in a situation where there is no room for further growth. Dartmouth has examined, using small area analysis, the cost of healthcare in a variety of markets and noted that the costs in Miami are nearly 3 times the cost of those in Salem. And as we will be discussing, what goes on in Salem is an important lesson for us. Understanding context is a critical consideration as we prepare for change. Fogel in the Fourth Great Awakening looked at how our society has evolved from the 1730s, from a period of liberty through a period focused on freedom, through social justice, and with the hippie generation in the 60s, a focus on spirit and knowledge. The fourth slide looks at others' view of how social change takes place on a large scale. Toffler's The Third Wave characterized the shift from the agricultural era to the wave of industrial revolution, followed by the era we're now in, the wave of information. And here again, it's important to note that the organizational structures we employ are based upon the industrial age and haven't really adapted the characteristics of the information age. Similarly, Florida's recent book, The Great Reset, looks at how society responded to the wave of industry, which resulted in an economic reset, which he characterized as the urban reset, resulting from the long recession of the 1870s. This was followed as industry needed to spread out, not build up, but spread out. Industry moved to the suburbs. And that shift in the economy resulted in the Great Depression of the 1930s. That is now being followed by a not so great, but perhaps as long depression of the 2000s. We don't yet know what that reset will be, but it is certainly underway. Scott, Roof, and Mendel, in a book entitled Institutional Change in Healthcare Institutions, looked at the change in healthcare and saw from 1945 a period in which healthcare was dominated by professional dominance. That was followed by the enactment of Title 18 and 19 of the Social Security Act, and that resulted in the federal age, which was then followed in 1984 with the birth of the managed care era. Interestingly, the managed care era was born as a result of the identification of 400% cost differences in cabbage costs nationally, as well as in the Los Angeles market where I was working at the time. The age of managed care is ending as the result of the identification of both dramatic cost increases and continued cost variations as documented by Dartmouth. On slide 8, we must ask, what will the new age be and what will be the requirements for success in this new age? Perhaps it will be the age of accountability, given the focus today on accountable care and accountable care organizations. Slide 7 lays out some of the changes that have occurred in healthcare since the advent of managed care. And these are a variety of systematic and formal organizational responses to the changes and the costs associated with those changes in healthcare. While integration and formal organization continues to be the focus of much attention, arguably it will be people and culture that lead the way to change. Steven Pinker, in The Modern Denial of Human Nature, says that human nature is the problem and human nature is the solution, and hence the importance of the informal organization. All organizations are some evolution of primitive groups and informal groups. Over time, these evolve into primitive organizations, followed by informal organizations. And beyond that, social organizations and social institutions are created, like those who employ most of us today. In spite of the fact that the social organization and the social institution are the dominant form, the informal organization continues to be the driving force behind those social organizations. Maslow's hierarchy of needs suggests that over time, as other needs are met, self-actualization will be the most important need to be addressed by society. Current argument within healthcare suggests that dollars are really the driver, and that unless we address the dollars, we cannot bring about change. Certainly dollars are important, but there's got to be more than dollars involved in bringing about the sort of change that we need. Price reform is certainly part of the solution, but price reform alone will not be successful. We have to look, as the next slide suggests, at what the elements of a group are. Using rough definitions of these terms, logos is the objective, orderly, knowledgeable aspect of the organization. It is the systems we employ. Ethos is the values, represents the values. Pathos, the feelings and emotions that we bring to our daily experience in organizations. And philos is arguably friendship or love, all important in a work environment. But the success of the industrial society seems to compel us to look for mechanical solutions to problems that are not mechanical. And the priority that logos takes and formal organization takes de-emphasizes the role of pathos, ethos, and philos. But success is not simply a production function that can be simply, easily, and only addressed by formal structures. Note on slide 13 the Dartmouth analysis of 6 markets in which they found both the costs in Miami and the rate of cost growth to be significantly higher than that in Salem. Now, the important thing about Salem here is, and slide 14 lays out the differences associated with Salem when compared with Miami. And I think the most important, as seen on slide 15, is the relationship of specialists to primary care visits. This is a result of the informal organization in Salem at the time, not requiring additional office visits and additional services provided by specialists. Their delivery system, which delivery system is a complex, adaptive, self-organizing system, found that they could get by, and Dartmouth's data suggests that their outcomes were better than Miami's. Their results were not produced by an integrated delivery system, not produced by large information technology initiatives. It was the result of the informal organization in place in Salem at the time. So the Salem solution, and it is a solution when compared to what's going on in Miami, is not complicated. It didn't require a lot of effort. It was simply the way they were. And Lao Tzu says the way to do is to be. Arguably, the folks in Salem were different. They didn't do different things or buy different systems. They were just different. And it doesn't necessarily have to be complicated if we call upon the informal organization. So the accountable informal organization that I propose is adaptive self-organizing system, and the features are networks. Networks are key consideration for the informal organization, and these networks are characterized by a high level of autonomy, reciprocity, and interdependence. Informal organizations lean more on theory O than theory E. Theory O is an emphasis on organization. Theory E is an emphasis on efficiency, economy, and engineering. Informal organizations thrive because of their organization and the non-logos elements of that organization. Informal organizations are invisible in nature, but very visible in terms of the affect and the effect that they have on society. Informal organizations are not directly manageable. They require a level of unmanagement, which is a difficult term to consider, but they can't be directly managed. They must be instead understood and facilitated. And the process of understanding the informal organization is a long-term one, as is any cultural initiative. The informal organization is arguably the seat of culture, and it is therefore the seat of accountability. And the informal organization must be facilitated in defining and spreading the culture. And those who don't conform with the culture won't be included in an informal organization. As such, all informal organizations are selective. Formal organizations are not readily able to select who their members are, but informal organizations exist entirely on the basis of membership selectivity. Members are selected. Members join because they choose to join. Informal organizations are built on the basis of structuration rather than integration, and the success factors are self-organization, social capital, and importantly, tacit knowledge. These defy the formal organization but are key to successful informal organizations. Informal organizations find a way to align their interests, and those interests are economic as well as other types of interests, and they result in a level of cohesion critical to success. So the informal organization relies less on logic and more on magic, and arguably most of our efforts require a level of magic to be successful at the highest level. A couple of tools I found useful in this process include the Values Priority Index, as seen on slide 18. This tool allows you to look at your organization or groups within your organization in terms of where their values lie. And I've chosen here a spectrum of business versus people, and another of clinical quality versus service. And each of the quadrants can be identified as a type of organization. A control organization is one in which business and clinical quality are both emphasized, whereas a tribe organization values people and clinical quality, and so on. When I used this with a client, we identified in this particular program a couple of dominant groups and looked at administration, management, clinical staff, support staff, board, and the community, and found considerable differences in what was valued. A process was then undertaken to build bridges based upon values over time to close these gaps. Another tool found on page 20 that I found useful is assessing group membership. Given the fact that informal organizations are selective, but formal organizations find themselves with established membership, it's important to understand how those members behave and the potential for those members to behave in productive ways. And I've arrayed spectrums of the future view of the participants. Is it pessimistic or optimistic? Who an individual blames? Do they accept responsibility, or do they always look to blame others? Group identification differs widely from no or low group identification to a high level of group identification. And finally, self-opinion has an important role to play in how a member participates in a group. Low self-opinion doesn't result in very good group participation, whereas high self-opinion, assuming it's reasonably high, not excessively high, is a much better participant in a group process. Understanding where your members lie in this will give you the framework for building corrective actions. I welcome you to contact us for information on these processes, as well as to contact us or find on our website some of the publications that we have produced recently on accountable care and the role of the informal group in bringing about a successful level of accountability within the health system. Thank you.
Thanks again, Philip. This presentation is complete.